has really taken over the EMS world by storm. Most of us, if not all of us, use his catheter. He's taught us the salad technique, etc. And I wanted to ask him to come to the show today to talk about some airway publications. I love to continue talking about kind of the best airway evidence that we have out there. So Jim, without any further ado, thanks for joining us. Sorry for for pulling out of what you were doing, but thanks so much.
Oh, heavens to Betsy, that's fine. Hey, thanks for inviting me, Peter. I'm glad to be part of your podcast today.
So yeah, so Jim, so we have had a number of guests on talking about pre-hospital intubation, airway. We obviously all use supraglottics and so forth. So I wanted to see if you could just and again, if you don't have any specific papers to talk about, that's fine. But I know that you're always combing the literature. You're involved in a lot of this evidence. If you can give us your take on the most recent and best airway evidence out there, or just kind of wax poetic on just you being you.
Well, just this morning I was looking over the literature as I was sitting at a breakfast counter, and I was a little surprised to find a few inclusions in the salad technique in chapters and books, more so than in papers. Although recently, I have a few friends out there in EMS who are medical directors. One of them published a case report of the use of something called the CDUC, which I had a hand in creating in the Aeromedical Network. And basically what they reported was the utility of using a handheld portable suction device. Is that me or is that you? Sorry, Peter, can you hear me?
Yeah,
so the handheld suction device in this case made a substantial difference in the care of a patient who suffered a grand mal seizure in the presence of the EMS clinicians. As far as any further publications, I'm just sort of kind of sitting back here, and I will occasionally just look at the papers that cite either my original simulation study in 2015 or in the summary article that I published with Chris Root and several other individuals back in 2020. So I don't have any.
Jim.
Yeah.
So I think this would be good because there are some people on this call who maybe don't know what we're talking about, don't have an idea of your background. So
okay.
I would love for you just to maybe give a quick background on yourself, and then talk about salad use in an airway that does not need an ET tube. Talk about salad with use with an eye gel, or just salad in general, because I think that a lot of people are kind of transitioning over to that. So if you can give some history on that, that'd be good.
Oh, most certainly. So guys, I'm Dr. Jim Ducanto. I'm an anesthesiologist in Milwaukee, and I've always had an interest in education and simulation. An innovation I came up with in early 2014, late 2013, was I've been hacking mannequins for many, many years, and the hack that I created in late 2013, early 2014 was actually to make the mannequin regurgitate. And I had made friends with the director of innovation for a suction company in Los Angeles called SCORE 3 or 4 years before that, and I invited him to a meeting to present alongside me at a workshop at the Society for Airway Management in 2010. And he coached me as to how to perform a good simulation of airway contamination. Like literally, if you're going to demonstrate a clinical suction device, you have to create a clinical scenario of regurgitation. So my innovation was I created this simulation, and then I found a way to make it easy to set up and perform. I invited colleagues from EMS, emergency medicine, critical care, and anesthesia into the fold. And at the University of Wisconsin and Madison Sim Center, we had a few wonderful meetings where we kind of hammered out how to do the simulation and what the techniques were to win the simulation. Because when you have a simulation where the mannequin is completely full of an airway contaminant, a simulated airway contaminant, I call it SAC. In a younger generation might laugh at that word. But the simulated airway contaminant, there's a certain formula as to how to approach the fully contaminated airway. And so what we developed was a cadence of approaching the airway with a suction in the right hand held upside down, like shaped like a laryngoscope, to clear the airway, and then use the suction itself as a tool to create space in the oropharynx and the hypopharynx by pushing and lifting like a laryngoscope to ease the insertion of a laryngoscope. A few years later, it dawned on me, how can I make basic life support better with this technique? And it was a little bit difficult for me to do that because I'm an anesthesiologist, and either I put a supraglottic in patients or I put a tracheal tube in them or I give them sedation. I don't do EMS stuff. And it dawned on me that if I put the suction in the left hand and held it like a laryngoscope, it would assist the insertion of the supraglottic airway because it goes in, it decontaminates, you push and you lift, and now the supraglottic, in the case of an eye-gel or what have you, it just drops in all the way to the hypopharynx in one move. The obstacle to optimal supraglottic use is you have to create the space at the base of tongue, lift the tongue and epiglottis off of the posterior pharyngeal wall to permit the device to slip along the posterior pharyngeal wall under the laryngeal complex and have the tip sit in the upper esophageal sphincter area. A simple jaw thrust doesn't do it very well in patients who have been given a general anesthetic. Oftentimes, an anesthesiologist will actually have to put their fingers into the mouth of a patient in order to make the device seat well. That's not an option for you guys because oftentimes you're dealing with patients who haven't been given an anesthetic. They just happen to be unconscious and they still have reflexes and they will bite your finger. You're not going to put your fingers in somebody's mouth in the type of scenario that you work in. So what we need for supraglottic insertion is we need a supraglottic insertion tool. Now you're allowed to use a laryngoscope in most places in the United States, as well as apparently the United Kingdom. In the London paramedics are allowed to use laryngoscopes to place eye gels. You're allowed to use a laryngoscope to do that, but as long as we're talking about using a rigid suction catheter to create oropharyngeal and hypopharyngeal space in essentially a decontamination and a push and a lift, it's the optimal way to place a supraglottic. Okay. Next little chapter in airway decontamination with resuscitation is if I'm in a position where they say, all right, Dr. Jim, look, we don't have all this stuff. You're going to have to bag mask the patient with an oral airway, and I'm going to do CPR in a 30-2 cycle. With the knowledge that we do have regurgitation during CPR, and I'm stuck at the head of the bed, I'm thinking to myself, well, you know, I could hold this mask over the patient's mouth while the CPR is going, but they're really kind of not getting anything unless you've got a high flow nasal cannula irrigating the nasal pharynx with high flow oxygen. Why don't I, before I put in the positive pressure breath, actually put a suction catheter down alongside the oral airway? And it doesn't have to be a rigid suction catheter, but if that's what you have, that's what you use. Why don't I suction the airway before I face mask ventilate if we're going to do the 30-2 cycle? Well, you know, are you going to wait to hear the gurgling to see that you're forcing aspiration? And I'm not saying that you have to do that every single cycle, but I think that we need to raise the concept in people's minds that if you're going to do BLS-based CPR, we should be able to do airway decontamination before we put in the positive pressure breaths. Okay, so that's where I kind of want to stop talking for a moment, Peter, and let you kind of guide us through what it is that you think is important when it comes to this topic.
Well, I think that you hit on it early on, which is that we should be leading with suction.
Yeah. It's funny to hear that. I guess it's not really funny. I think, you know, look, among us, everybody here, whether you're a physician or not, you would love to make a positive impact on current and future medicine. For me to have done that with something that I consider pretty simple, well, I guess that's a good thing, especially since it's simple, because it means it's generally applicable to all levels of caregivers, from the first responders all the way to the top levels, to the physicians, all the way to the first responders. So what I'll have to say about SALAD is when I give seminars to EMS groups, the first thing I single out is I said, all right, who among you is an EMT basic? who among you are the lowest level providers in this group? They identify themselves and they look sort of like, I don't know, they just sort of like have a dejected look on their face. Sometimes they says, okay, we're going to focus on you first. We're going to have you do this. First of all, we're going to have you do everything that everybody else is going to do. You're going to intubate these mannequins. What I want to do is I want to focus on you first because this is absolutely completely essential. If you're asked to do anything, you will be asked to use your BLS procedures, which include the insertion of a supraglottic airway, at least in the Midwest. Apparently, in other parts of the United States, you have to be a paramedic provider to place a supraglottic. Apparently, in Wisconsin, you can be literally a first responder in most parts of the state and put these things in, by the way. And I think there's a pilot project in New York State to let EMT Basics place the supraglottics, which is what they should do. But I focus on the basics. Okay, now this is not to disrespect anybody at a higher level, but what you have to do is you have to basically understand that the people who are going to do the work, they need to be given the confidence, they need to be given the encouragement, they need to be given the excitement, the energy to do this stuff, because you don't want them to look at a nasty situation where the mouth is full of blood or vomit and turn around and say, you know what, not today, I'm not going to deal with it. You want them to say, oh yeah, I know what this is and I know how to fix it. I don't like it one bit, but I'm going to come in here, I'm going to do the best job I can do. That's the attitude we need to instill as teachers and as leaders.
So let me ask you though, how many agencies out there are still using the Yankauer, and how many agencies that you have gone to visit actually have a mannequin that could provide regurgitation? I have, I have in all my agencies here in South Florida, I had to call the trauma center, Candace, I'm not sure she's on today. She's got the mannequin. She drove it over to Davie Fire, to Coral Springs. We already have one in Palm Beach County. But it's my sense that not many people are doing it. And I would love to hear from the people in the group, like, Jonathan, do you guys have the soiled mannequin, the airway mannequin? Do you guys do that currently in South Metro in Colorado?
We do, but we're also using the Ducanto section.
Right. So I guess the question is, how many people out there are able to do this kind of training? Oh, there's Candace. Hi, Candace. Can I pick on you first? If I can pick on you for a second, how many agencies have called you out to do this type of training?
So we wrote a grant to actually get some airway mannequins. We have 8 now that are available to all of our EMS agencies in Broward County. So they check them out on a regular basis. So we either do a train the trainer, we can go to any of the stations or agencies, or they can check out the mannequins and use it on their own. So
Okay.
we've had all 18 agencies use it, and then we bring it to the First Air First Care conference as well. So
Are still using Yankauers?
I think there's several that are, or some agencies carry multiple devices. So I always challenge the medics to check their truck and what actual devices they have so that they can check both.
Okay. Let me first pick on Angus across the state, and then I'll go to Marv across the country. So Angus, is your sense that across the state, as a state medical director, that this simple technique of lead with suction, whether it's supraglottic or ET tube, is being utilized? Not sure if
I'm sorry, Peter, I'm multitasking. Was there something directed at me?
Yeah, I just was curious what your thought was on how many agencies across the state are practicing on the use of suction of the soiled airway.
In terms of the actual sort of salad technique,
Yeah.
I do not know, because everybody has sort of the ability to do their own protocols. I have not seen that we've even actually gotten very many sets of protocols uploaded into the shared thing on Mobilize, though that's a good point. It would be great for more people to upload their protocol books there. Yeah,
you're right. Yeah, so I guess the reason I'm harping on this, Jim, and everybody here, is because I would say that we're pretty proactive here, but some of these minor things like using a better catheter, using a better technique, it takes a lot longer for that kind of thing to make it into a training session. And so I had the pleasure of speaking to Marv this week. Marv, you're the Airway guy. What's your take on the skill set in EMS with respect to what we can do better?
Yeah, thanks, Peter. By the way, I'm honored to be on with Jim. Hi, Jim. How are you? We have shared many stages together.
How's it going?
Of course, I've shared them longer than anybody. But anyway, seriously. So we have Mr. Puke, which is what we call him. We don't have standardization in all our agencies on the suction device. The Yankar is still too common. Ducanto is sort of running the race well. And as you know, we do all BLS is iGel. We train every quarter, even if it's only for 15 minutes on iGel. We try to train that suction is first and iGel is second. We try, and of course the ALS, Peter has seen some of our videos. Most recently, I sent him a 10-month-old that was unfortunately nursing mom who'd been sucking on her fentanyl, which was a very sad story. But it shows a video, it shows the intubation, the clarification, and even the NG tube after the intubation. So we're trying to change that it's not one particular action. It's a series of actions that combine to achieve what you need to achieve. We also try to train that if the iGel is working in a CPR case and you're able to provide whatever additional suction, that you work in again on an as-need basis. So I know Jim agrees. I also know that we're not as good as we need to be. You know, we'd like to think we have got the best of something, which we always don't. So, but thank you. But I do think that the concept of a process rather than a procedure is the key.
So Jim, let me kind of pitch off Marv's comments, and I'm going to give you a scenario. And you know, Marv has some great videos, but I'm going to give you a scenario. You know, we have in some of our agencies we have DSI. Okay, so we give the ketamine, we give the rock, and then we go for the tube. You know, interestingly, we've looked at our data and we want to publish this, that you know, a lot of our folks, we actually allow them to just give the ketamine, evaluate the what's going on, and oftentimes they're not even giving the rock. But the scenario that I really wanted to ask you about here, you gave the ketamine, you oxygenated them, you had the 3-minute time period, you gave the rock, and now you can't get the tube, right? We have a default right to iGel.
Okay, right.
What do you say? What do you say about that?
You cannot get the tube, correct? You cannot get it, right?
Correct.
I think the supraglottic airway makes the most sense. It's what you would do in anesthesiology. If you've given the rocuronium, your concern over active vomiting is gone. You're not going to see active vomiting because you've given the muscle relaxant. The only reason you'd have active vomiting of any sort is that you insufflated a substantial amount of gas into the stomach with face mask ventilation, right? Okay, so your risk of massive vomiting is gone following the rocuronium. There's going to be passive fluid that comes up. But the most important thing here is the safety of the patient. So you've administered the essentially the hypnotic analgesic, the ketamine. You've administered the rocuronium. You've had a failure to intubate probably because of a failure of tracheal tube delivery, not of laryngeal visualization. The problem in the current day with video laryngoscopy is tracheal tube delivery. It's not a problem of laryngeal visualization. Assessing why the tracheal tube delivery is not going well, that can happen after you place the supraglottic airway. And if it's safe to transport with the supraglottic airway, you do it. You have to make a decision. Okay, did the person who did manage the laryngoscope and manage the tracheal tube, are they going to be able to identify what the difficulty in tracheal tube delivery was? Do they understand that when the laryngoscope was in the mouth, they allowed the tongue to hang over the right margin of the blade, which reflexively will push any bougie or even tracheal tube that's cannulated with a malleable stylet, it will push that posteriorly into the esophagus. The fix will require the insertion of an index finger into the mouth alongside the laryngoscope blade to push the tongue to the left of the laryngoscope blade. And what you do essentially is dilate the tract for the delivery of the tracheal tube so that you can successfully deliver the tube. So I'm simply saying here, I think if we circle in as to why we will fail to intubate with video laryngoscopy, it's because of tube delivery. How do you fix it? You dilate the tract with a finger, which is safe after you've given an anesthetic and given a muscle relaxant. You're not going to get bitten. Now, if you're using a bougie and you're using a laryngoscope that is subtly or severely hypercurved, you're going to have a problem using a bougie. Just letting you know. The Ridges stylet comes into its own when you're using a hypercurved video laryngoscope. There is a new bougie or two that do work with hypercurved video laryngoscope. As an aside, I am tied up now with Endosurgical, who is selling Richard Levitan's, they call it the Universal Stylet Bougie. I have used it clinically. I think you need to practice with that in simulation before you take it to the field. It's not a cure-all. It is a good device. And when I initially used it, I got to be honest with you, I didn't really like it that much, but the device grew on me because I used it in simulation, then I used it in clinical practice, and it is a good idea if you guys are using glide scopes, you're using other hypercurved video laryngoscopes. So I know I've kind of branched out here, but I think you were hoping that I would go off on this type of a tangent with you, you know?
That's right. Yeah, no, that's all great. Marv, go ahead. Go ahead.
Yeah, just comment back to all of you. So first of all, the process is what Rich Levitan has often said, is not intubation, it is epiglottoscopy. And as I ask my anesthesia colleagues, what is the most important ligament in the body? And no, it's not the penile one or anything like that. It's actually the hyoepiglottic ligament. And I work a lot with Andy McCoy down at UW, and we teach the NAMSP course, which Jim has been kind enough to occasionally help with. And what we focus on is the ability to enter the hyoepiglottic space and lift. That guarantees you that beautiful opening that you saw, Peter, the other day on that 10-month-old is right there for you to put the tube in. And the issue of bougie is mixed emotion. We're playing with that new one. The older ones don't do well, even with the minimally hyperangulated blade like we have with the UE scopes. So again, just understanding that it is epiglottoscopy, it provides the pathway to the glottic opening.
I think
Marv.
what Marv is
Go
really
ahead,
saying
go
is, I mean, we're not going to have a problem finding larynx anymore, especially if we do the proper training. If you are all observing people intubating under stress, the left hand is going to be still and the right hand is going to be shaking. I'll just tell you the truth. I mean, watch for it, and you're not watching for it in order for you to give the person any type of negative feedback. Just pay attention to the fact that this is the situation under which many people are practicing. Maybe their hand is shaking. If any of us who haven't intubated a pediatric patient in 10 years is asked to do it, there's a chance that your right hand is shaking while you're delivering the tube. Just saying, right?
Yeah. Awesome. Great comments. Let's see. We have a few more minutes, 3 minutes to be exact, because then I got to jump to the other webinar. But I would love to see anybody else have a comment while we have Jim on the line. Any thoughts? Candace.
Just one last comment and plug. We have Chief Carter here on with us, and we are planning for Dr. Ducanto to join us at First Air First Care to do some more airway management courses. But if anybody wants to borrow the airway mannequins or need some more support on how to roll it out, give me a call.
Awesome. So Candace, people will reach out to you, and you will bring the mannequin over to the agency, correct? Or do they just come in and pick it up?
They can check it out, or we can meet with them and provide the training as well, whatever's needed.
Okay.
Awesome.
Peter,
if anybody
Shameless Commerce, NAMSP Airway course will probably be on the Wednesday of the NAMSP meeting. We're still working out details, but chance to work on fresh frozen cadavers.
Cool.
And for anyone who wants to know, NAMSP is not only for physicians, so they take professional members, and we encourage everybody, if you're in EMS and you're in leadership, that you don't have to be a doctor. It's a great conference to be at. So please do that. And personally, what I do, just so Jim knows, and Candace, and because Candace has been there, she's come to my department. I actually show a couple of Jim's videos. They're all on YouTube. Particularly, I show the one where the eye gel is already in, and then there's soiling. I think you were in Bend, Oregon, where this video was recorded, because I saw you with Peter Hasek on that video. But then you actually show how you unseat it, and then you suction, and then you reseat it. But I think that the point you started off with, where you're using the Ducanto to open up that airway, move that tongue and the jaw while you're suctioning at the same time, I think is something that, it's one of the main reasons that I wanted you on, is to let people know that you're not really just pushing your device, but like it makes such a huge difference in these patients when you're going in with the suction, rather than us as medical directors getting the video and all we see is just a bunch of stuff. When the video goes in, we're like, no, we shouldn't, So I see more of that than the other, which is really why I'm trying to push the point here. So, Jim, give us a last word before we have to pop off here.
Well, I think that this is a work in progress. I really look forward to doing this for quite a long period of time. I mean, I got about 10 years or less of clinical work left, but my job is not going to be done for quite a long time, and you guys can count on me. I'm really enjoying interacting with all the medical professionals across the country and across the world to just better airway management. It's like, yeah, we kind of do have to train our replacements, but the truth is we get better by getting better together.
Well said. Well said. I love that. All right. Well, thank you so much for coming on to Florida, for helping us out, and for all you do. Appreciate you, and we'll be in touch.
Thanks again, guys. Have a great day, everybody. See you later, Candace. I'll see you in Florida. Bye-bye.
All right. So I'm going to join the Eagles side. Angus, it's okay if it's okay. You want me to just to record this or stream?